Medicine must concern itself with both the soul and body of the patient. The ethical responsibility touches on who should, can, or will be saved, and medicine is not an exact science like mathematics or physics. For example, a 5-foot measurement remains 5 feet, whether it be in Dubai, Malmo, Alexandria, London, Santiago, Mexico City. All those who practice the healing profession sooner or later will be confronted with ethical dilemmas. And tonight, we have a distinguished professor from Vanderbilt University that will touch on some of the compelling conditions, their treatments, death, and dying.
The founders of the Gerontological Society came together in the 1940s, knowing that improvements in public health, breakthroughs in biological and medical research, and higher standards of living would result in growing numbers of older people.
The origins of the Gerontological Society are firmly based in science. The question was now, what kinds of things will alter lifespan? What can you do to manipulate lifespan? As years have passed, we've found that the number of years of life is not nearly as important as the quality of those years.
The charter members came mostly from the biological and medical fields. And though they did not share a neat scientific theory, they realized that the study of aging required a multidisciplinary approach.
To study the diseases that old people have is quite appropriate, but it is not gerontology. You're not going to find out very much about aging if you study a disease simply because old people have it. The social conditions are important in terms of what kind of a life old people can live. What I've seen in the last 25 years, let's say, is a marked
Nashville. I am Michelle Garcia, your host. Tonight we will be discussing men's health, especially the draft recommendation by the United States Preventive Services Task Force and due for official release in October 2011. Tonight to discuss men's health, I have with me Dr. Arnold W. Malcolm, MD, MBA, FACR, Professor and Chairman of Radiation Oncology at Vanderbilt University Medical Center, as our guest. Dr. Malcolm got his BS degree from Kent State University in Ohio in 1969 and his MD from Meharry Medical College in 1973. He completed his residency at Joint Center for Radiation Therapy, Harvard Medical School, where he became chief resident in 1978. While he was also a research fellow in radiobiology at Harvard School of Public Health, both in Boston, Massachusetts. Let's see. Dr. Malcolm, you are certainly highly qualified in this area of radiation oncology, and I am glad that we have you here today. Tell me, what is radiation oncology?
It's the study of cancers or neoplasms treating with radiation, which is similar to getting x-rays as a chest x-ray. However, the energy of the x-ray beam is significantly higher than that, and the radiation basically disrupts the DNA or the mechanisms of the cancer, and therefore killing them.
Okay, so it's kind of a concentrated beam. All right. Well, so it's a form of cancer treatment for patients.
Yes.
Okay. What stage, I mean, is this like the first course?
No, radiation oncology can be used alone. It can be used prior to surgery. It can be used after surgery. It can be used prior to chemotherapy or in combination with chemotherapy at the same time. So it can be utilized in many different ways at different times along the treatment for a patient for cancer.
Okay, so it can be used independently or
Yes.
concurrently with other therapies.
Correct.
Okay. Well, cancer, when people hear the term cancer, they think terminal. What happens when radiation cannot cure or mitigate the disease and suffering and the patient does pass?
I think the first thing I should say that when a person hears the word cancer, it does not mean, it's over. That's not true at all. There are hundreds and hundreds of types of cancers involving everything from the top of your head to the bottom of your feet.
Yeah.
So I think it really very much depends upon what type of cancer that individual may have. And then there's a broad category. With radiation oncology, also chemotherapy, the broad categories are palliative, that is, you're trying to help the patient in recognizing that they are not curable, but they have a symptom that you're trying to ameliorate, so their quality of life is better. Then the other part, which we like to always think about, is curative or definitive. So we're using that treatment to totally eradicate the cancer.
That's awesome. Well, what are the ethical ramifications of this?
Well, the thing is, I think you have to be first very, very honest and straightforward with the patient in a kind way, explaining to them the intent of the therapy. And that's what the problem is. Sometimes patients don't want to hear, unfortunately, when you say, well, I cannot cure you of your disease, but I can make you feel better and I can make this pain go away in your bones. If you have bone pain, patients come in sometimes with very severe pressure on their spinal cords.
Right.
They can't urinate, they can't move their bowels, and the radiation can relieve that pressure, therefore that improve their quality of life. It's the communication which I think is the most important part.
Okay, so it's just being upfront with them. That's awesome, because I didn't know that, that you can use radiation to just kind of mitigate the symptoms, kind of minimize them.
Correct.
Let's see here. Are there new or recent advances in the treatment of cancer?
Multiple new advances, both from surgical avenues, chemotherapy and radiation. Just to give you some examples. Some of the new techniques in surgery are less invasive, and that they're done with robots and other things, and so the patient can tolerate the surgery better. Their recuperation time is markedly decreased. In regards to chemotherapy, we're looking at specifically targeting the action of the cancer cell that's causing it to grow. It's called targeted therapy, and so there's a lot of that investigation going on. Radiation oncology, there are new techniques increasing the long period of radiation from like 4 to 6 weeks down to a week. Making the fields actually smaller and being able to pinpoint what you want to treat, and therefore treating less normal tissue. So there's a lot of different things going on simultaneously.
Well, I'm impressed by that. I've known in the past people who have been undergoing radiation therapy and would have to go daily. For the most part, it is a daily treatment. What people need to recognize that treatment only takes usually 10 to 15 minutes. Okay.
Actually, the radiation beam is only on 2 or 3 minutes. The majority of time is setting up that patient accurately so that you can deliver that beam where you want to place it.
Okay.
There's no pain, nothing involved in it. You don't even know the beam is there. It's like getting a chest X-ray. You don't feel anything.
Right.
However, it is making a difference.
That's awesome. So it seems to me radiation oncology is difficult. I mean, sounds like it has to be precise.
Yes.
Detailed to the minimum, to the maximum. Tell me, Dr. Malcom, what's the difference between external radiation and seed implantation?
Okay, so external beam radiation means it's delivered through a machine that is maybe 100 centimeters away from the patient. It's like taking an X-ray. And the beam passes through the air and then goes into the body and then is directed to the area of interest.
Okay.
And when it comes to brachy or brachytherapy, you're actually putting in radioactive material either directly into the tissue, the tumor, or putting it into instruments that are right next to the tumors. The term for brachytherapy means close. That means right next to the tissue.
So in that instance, with the brachytherapy, how long does the patient have to endure that?
Excellent question. Yeah, I should have mentioned that brachytherapy can be given in different ways. Some are called temporary implants, where the radioactivity is only in the patient for a certain many hours or days, and some are permanent. So some patients, we put the radioactivity into the patient. For instance, prostate cancer, in most instances, it can be done another way, is that we put the seeds into the prostate, they stay there forever. And they actually decay over time. So the patient's actually radioactive.
Oh.
For a short period of time.
So they glow? No.
They glow. They glow. No, they don't. They don't glow. And we can actually release them from the hospital because the amount of activities that's being delivered outside the gland is so minimum that they're safe to be in the community.
Okay.
Yeah.
So they're okay to come into contact with others just because the amount of radiation that's being released is so minimal.
It's minimum, and it's pretty well right around the prostate itself.
Okay.
Yeah.
So it's very specific.
Otherwise, we couldn't let the patient out of the hospital. Yeah.
Because they'd give everybody else here's radiation. Well, are there any times that you consider palliative or curative treatment? At what point do you consider palliative versus curative?
Well, it depends upon when the patient or what stage the patient comes in. And in general, cancers are classified as from stage 1, stage 2, stage 3, stage 4. Stage 4 usually means it's metastasized, that is, has moved from its primary site to some other site. So, for instance, since a lot of discussion will be about prostate cancer likes to go to other places, for instance, the bone. So if the patient has disease in their bone related to the prostate cancer, then you don't give them definitive therapy, you don't operate on that patient, you don't actually radiate the prostate either.
Really?
Because the disease is already outside the prostate. So if it's in the bones, they're having problems with bone pain, or we're concerned that the disease involving the bone is going to affect them, they're going to break a bone because of disease, we will treat that. So that's called palliative. The patient has pain, you're palliating that pain. Okay. Or sometimes we call it prophylactic palliation. They can have a lesion within the bone, like in the leg bone, the femur, and that's a weight-bearing bone. If you don't treat that and the disease progresses, even though they have no pain, it will break.
Yeah, it will
So
fracture.
you have to treat it before that happens. So there's different ways.
So in that case, you're not going to aggressively treat the prostate, but you're trying to treat and prevent other injuries that could occur causing the prostate
and
cancer.
that has to be made very clear to the patient, because patients often come in and say, well, what about my prostate? Well, that's not the issue. The issue is this disease in a different place.
Okay, I understand that.
Okay.
Sometimes they come in trying to bargain.
Unfortunately, every day.
Yeah.
The patient is trying to bargain with you about their treatment or what's going on, or is not bad as I think it is, or back and forth, and you have to be honest and be very forthright and try to help that patient understand what's going on. Yeah.
Well, I think a lot of times, even when they know that they're sick, they're in denial, and that denial costs time.
Yes.
So with regards to the prostate gland, what are non-surgical options that are available, that...
Well, okay, so if you're saying a primary treatment, definitive, when you're trying to cure that patient of cancer, usually I would just be very honest, it takes me an hour and a half to 2 hours to talk to a patient about the treatment.
Right.
Because I try to include everything. And that includes even they said non-surgery includes surgery as a potential option, and I'll mention that more about that in a minute. It also includes radiation, be it external beam or external beam, or it can be, which we may get into in a few minutes, no treatment at all. Even though they have prostate cancer, diagnosis has been made, you have to you should make a discussion with the patient concerning, do I do anything about it? Do I do nothing about it?
Right.
And sometimes I say, patient, no, leave it alone. I believe it or not, I say leave it alone.
You hear sometimes about fast-growing cancers and slow-growing cancers.
Yes.
Where does prostate cancer fall off in that range?
The majority is slow. The natural history of prostate cancer is 15 to 20 years.
Wow.
So patients usually say, well, when did I get this prostate cancer? My answer is, don't have a clue. You probably had it 5, 6, 7 years before we even discovered you had it. It's a slower growing tumor, and that's some of the issues when it comes to this task force recommendation.
Okay.
Yeah.
So what type of symptoms would a man look for with this prostate, since it can just kind of creep up on you?
Well, prostate cancer is an insidious disease. That means that it's there and you don't know about it. And for a matter of fact, 95% of patients have no symptoms of prostate cancer. It's a mistaken thought that, I cannot urinate and therefore I have prostate cancer. No, that's because as we age as males, our prostate gets larger and larger, and it kind of obstructs it, and therefore you have trouble urinating. But prostate cancer has no symptoms at all.
Okay.
Now, before the advent of PSA, majority of patients that we saw with prostate cancer came in with bone pain. They already had metastatic disease. because you don't know. You have no symptoms, and then you have bone pain, and then it's distant disease, and then it's discovered.
Wow.
So PSA has made a difference.
So PSA, now that's not alphabet soup. What does that stand for?
Prostatic specific antigen. So that means there's nothing else in the body that creates PSA except the prostate.
Okay.
So you may hear a lot of comments about ovarian cancer, pancreatic cancers, CA-125, all these different numbers. They are not specific. They can go up with, say, for instance, ovarian cancer, but you can have an elevated CA-125 or something else.
Okay.
But PSA is only for prostate cancer, nothing else.
Wow.
So it's very, that's why it's called specific, because that's what that's related to prostate.
That's wonderful, because you know, you can have something be sick, like you can have a cold. You could have just a cold or flu, or it could be lung cancer. But PSA, the PSA tells you
something's wrong with the prostate. Now, let me make it very clear. A person who has a male who has a prostate is going to have a PSA evaluation. I mean, I don't mind saying on TV, my PSA, I think the last time I had it checked was about 0.5, very low.
Okay.
Okay. So that's saying, well, you got a prostate, but it doesn't mean you have cancer.
Right.
It's when it gets elevated to a certain amount, therefore it suggests that you may have prostate cancer. It's not definite also.
Right.
You can actually, when you have a rectal examination, okay, for either trying to evaluate the rectum or the prostate, the PSA can actually be elevated just slightly, just a teeny bit, just because you massage the prostate.
Oh, okay.
So patients that come in, I say, well, have you been riding a bike? Well, no, you need to not ride the bike for a couple of days before you get your PSA evaluated, because it's going to go up because of that.
So you're saying that men just across the board are going to automatically just always have some level of PSA in their system?
That's normal. It's normal.
The reason why you say like riding a bike or anything, that would be something that would kind of stimulate or...
It's been, you're massaging the prostate, you know, which is nothing wrong with that, but the PSA will go up. You can have an infection in your prostate and cause prostatitis, that is an inflammation in your prostate, the PSA will go up.
Wow.
It doesn't mean you have prostate cancer.
Okay, so if you've just been walking your dog, and then you come in and your PSA is elevated, then you kind of...
I mean, it goes down very quickly, but you know, if you do it immediately before you have the blood drawn, it's going to be potentially elevated.
And so are the PSAs done in a serial evaluation, or is it a one-time test?
No. Well, right now, the recommendation has been, you know, after age 50, get a PSA at a minimum once a year.
Okay.
So, you know, you get the PSA, it could be elevated, could go up, and it can go down, and you can get a PSA and it'll be, we'll say, 5, which is elevated, and you go back 3 months later and get another, and it's 3. It bounces. It's not that. That's what people don't quite understand. You have to evaluate the PSA along with the patient's age, their race, their family history, the examination or the feeling of the prostate with the finger. All those things come into play when you try to understand what's going on in this individual.
Okay.
Yeah.
So there are family historical kind of implications as well with this prostate.
Oh yes. Unfortunately, if you are a male and your father had prostate cancer and your father's brother had prostate cancer, in your lifetime, you will get prostate cancer.
Wow.
That's just the way it is.
So you just know to be on guard.
Yes. And so one of the questions we ask patients, you know, do you happen to know what happened with your father and your brother and relatives?
Right.
Because we're trying to understand, okay, is this related to this person? And then when I find out that a patient's father and brother have prostate cancer and they have male children, I say, better make sure that they get a PSA, perhaps not waiting to age 50. Now things are changing, but at that time, at age 50, but perhaps you need to start getting around 45 or so.
Okay, so just kind of be more proactive.
Correct.
If there's a family history.
Correct.
Now you say things are changing. What kind of things are changing?
That's what you mentioned at the beginning of the program in regards to the Preventive Task Force, U.S. Preventive Task Force. Well, the recommendation now, as of October, although some people are writing back and forth, October 11 of this year, is that PSA will no longer be done to anyone. No one.
Okay.
All right.
Let me get this. So they're saying their recommendation is just don't do a PSA.
Correct. So what happened is that we've been studying prostate cancer for many, many years, trying to understand its natural history, trying to identify as best we can what patients need to be treated, because some patients don't need to be treated,
right.
and which ones should be treated. So the task force looked at about 5 major papers evaluating the PSA and how it related to a patient dying of prostate cancer.
Right.
And it was about 260,000 men over 10 to 15 years they followed, both in the United States and all throughout Europe.
Okay.
And the data basically demonstrated or said that there was no influence upon patients' lifespan in dying of prostate cancer. The numbers came out to 0.03% change. That's not statistically significant from the point of view it had any effect on your livelihood. So they made this big, broad statement and said that's what we need to do.
Just no PSA?
No PSA on anyone. Now, 3 years ago, they first came out and said we should not get PSAs in men age 75. Okay, and that makes sense because they're saying, well, prostate natural history is long. Unfortunately, men will die, or a lot of people will die before, the prostate cancer gets them. So, but now they're saying more data suggesting no one gets it. Doesn't matter what age, what race, or anything else. So it's a huge controversy. Everyone's talking about it. A lot of us feel that you're throwing out the baby with the bathwater.
Right.
There are just too many issues. And, most of the people on this task force were epidemiologists, preventive medicine people. They don't deal with patients every day and have to say to the patient, well, you have prostate cancer.
Right.
So that's been an argument. The other is, well, how are you going to, they said, well, you need to counsel the patient. Well, how can you counsel the patient in regards to PSA or prostate when you have no data?
No data.
You got it. So no data, how do you do that? So it's all crazy as far as we're concerned. So, and then recently, although I think most people didn't hear about this, the NIH, National Institute of Health, was talking, and they haven't made a decision yet, about patients who have what we call low-risk prostate cancer. I'll tell you what that is in a second. Okay. Perhaps from their biopsies, if there's low-risk prostate cancer, we have to designate them differently and say, you don't have cancer. That doesn't make any sense. So the biopsy shows you have cancer, but still you have to come back and say, well, you don't have cancer. So how are we going to explain that?
Right.
But basically what they're saying is the PSA, there are 3 things we kind of look at when we're looking at patients for prostate cancer. One is the PSA, and if a PSA is 10 nanograms per milliliter, is how we look at it, 10 nanograms per milliliter or lower, we consider that a low PSA.
Okay. And low is good?
Low is good.
Okay.
Combined with, now this is combined with a biopsy showing what we call a low-grade tumor.
Okay.
We look at that, and we look, and with the digital examination, that is putting the finger in the rectum and feeling the prostate, and you feel no lumps and bumps, we put all those patients in what we call low-risk patients, okay?
Okay, so you have to meet all 3 of those criteria.
You have to meet all 3 of those criteria.
In that category.
You got it.
Okay.
So now we're struggling, well, what do we do with these patients? So what this I think what the preventive task force is saying, well, these patients have low-risk disease, therefore, they're going to live, many years, and they'll die of something else before they die of prostate cancer.
Issues with prostate.
So that's what's going on. And now we have begun to subcategorize the patient to very low risk, intermediate risk, and high risk.
Okay.
And all these things mean different things are changing. That is, their PSA is greater than 10. There's a mass or lump on their prostate. All these different things come into factor. But the hard patients to deal with are what we call very low risk and low risk. And what do you do with those?
Right.
Now, when we see a patient with prostate cancer, I tell every patient, you don't have to do anything in regards to treatment. You have an option to have some type of treatment. And I say pick your poison because you don't get anything for free. Yeah. Now, I don't mean monetarily, but I'm saying that there's some risk involved as far as toxicity or complications, be it acute or chronic, from no matter what, surgery, radiation, there's some risk there. Or you can make a choice for what we call simple watchful waiting. But I think people don't understand there are actually 2 grades of watchful waiting. One, watchful waiting means doing no active treatment for the disease itself. Yeah. Okay. Now, one category is what we call active surveillance. That is, a patient goes in, gets repeat PSAs every 3 to 6 months, may have a biopsy of the prostate every once a year. That's active surveillance.
Okay.
Then the other category is watchful waiting, where you really don't do much anything, and you might get a PSA every 6 months or a year, no biopsies, and any of those things. But our problem is we can't truly identify every patient, say your disease is not going to progress quickly.
Right.
And so that's a dilemma we're all in. So we're trying to figure that out.
So would it be safe to say that you're on the side of maintaining the PSA?
Oh, definitely. Now, I had to say my position is yes, we need the PSA in order to counsel patients. Now, the number that has been around is 4 nanograms per milliliter, or slightly higher than that. I think that number perhaps a little too low, and a lot of people are being evaluated, which perhaps they don't need to be. So I feel maybe we can push that number a little bit, like 6, because remember we said 10 or below is considered low risk. So maybe pushing up 6, you may not then evaluate maybe 10 or 15% of the patient.
Okay.
Therefore, perhaps saving the toxicity and the cost.
I understand that.
There's a psychological part in here too. If the patient gets a PSA and it's elevated, then you're trying to say, well, don't do anything. So, well, I got cancer. What am I going to do? So there's a lot of issues involved. It's pretty complex.
Yeah. And it's good to get on top of it. And I can understand how important a PSA annually would be. I mean, it helps you to stay ahead.
It's not expensive test. It's simply a blood test.
Yeah, it's just a blood
and a
draw,
rectal
from my
exam. It should be combined with a rectal exam, not just by itself.
Yes.
But the problem is what this stands for, saying you cause anxiety in the patient because they get the PSA, and then because they get the PSA, then you end up pushing them down the route, and now they have to get a biopsy. Biopsy is not painless. It's uncomfortable, but it's risk of infection, all those things. So then you add all these. That's what they're adding. Say all these toxicities you're potentially adding, and then you decide on the treatment course, and then you have the risk of surgery, and complications of surgery. And then you have risk of radiation, the complications of radiation. And so you're adding all those toxicities. And when you're saying, well, you could have done nothing and be fine. I've seen men at age 90, I'm begging them, no, don't do anything. They just, no, you're going to treat me. I said, this is crazy.
Yeah.
You're 90. So that happens too.
So I think in the long run, it boils down to patient needs to be made aware.
Correct.
I think that, in my opinion, just in listening to you, that you need to make an informed decision.
Correct.
Informed. And having that information is of essence to be able to make an informed decision.
Correct. That's
well,
what I
thank
feel.
you so much for being with us this evening on Let's Talk About It, and I hope that everything goes well in the mandate for making it still be a mandatory thing on an annual basis.
Thank you very much, Michelle.
Thank you.
I enjoyed it.
And thank you for watching.